pretrial and with our policies and procedures. There's still a lot of progress for us to make, and we'll continue with that. But that's been really very helpful, again, as we've rebranded from law enforcement model, where the idea was very much to drug test and arrest in pretrial. We've moved away from that to more of a restorative, case management-based civilian model, where we're referring people out, for services. They still have bond conditions that they are absolutely held accountable to, but at the same time, the idea is to start that change process pre-trial. So that project is finishing up, and last fall, our pretrial supervisor, Shelby Hilden, actually participated at the NAPSA conference in kind of a roundtable discussion about the work that we had done. And either Shelby or I are going to do something similar this fall, just kind of wrapping up the project to talk about the change and, again, the work that we still have ahead of us. But that's kind of where we're at with pretrial. Any questions?
All right, then moving on to testing services update, and shockingly, it's Phil again.
If anybody else wants to jump in. Well, yeah, Anjali, you can jump in. So for drug testing services, we had in March opened up the kind of satellite facility up in New Richmond at the Services Center to Tuesdays. That went well, and we have now expanded. And starting this week, we are now offering testing Tuesdays and Fridays in New Richmond. So those particular days, any diversion, pretrial treatment court, or CPS case that is ordered to test with justice support on Tuesdays and Fridays will need to report to New Richmond. And then Monday, Wednesday, Thursday, we'll be offering the testing here at the Government Center as always. The other couple updates with that, it's interesting timing that we're expanding while our individual that tests is going on maternity leave for 3 months. So we in Justice Support are backfilling that. So myself, the supervisors, all the case managers are, picking up the slack for the next 3 months. So we are backfilling. So have maybe just a little bit of patience with us if your clients voice that things are not maybe as smooth as they are. It's because we're kind of doubling up on our duties. We've also changed up the hours. We're going to be 8 to 4 for right now, just to accommodate our staff schedules. But we're pretty happy. I don't know if anyone else has received any informal feedback from their clients in diversion or CPS, but anecdotally, the clients seem to like that satellite location in New Richmond, that, roughly 50% of the people that we test anyway live in that area, and so it seems to be maybe removing that transportation barrier. Right now it seems to be going well, and we'll continue to evaluate. I think the next biggest thing drug testing wise for us will be in September, October, when Justice Support downstairs moves, so that location where Justice Support has been for the last 3 years will no longer be, and we will all be on the second floor. So there will be another physical change of location for clients. So just maybe help to reinforce with our clients that just patience, and we appreciate that. But yeah, we'll be physically moving the drug testing from the annex that I call it down by Justice Support down by the Sheriff's Office, upstairs on the second floor. The South Addition is where we'll be starting September, October.
Phil, can I ask a question about the hours? So for a lot of the public defender clients, if they have a
microphone, if you could.
Oh, so I'm from the public defender's office. Very public defendery way of rigging my name tag here, because neither Attorney Dolphy nor Attorney Sartorius are available today, so I'm the third choice, I guess. With regard to the hours, I have clients who their hours aren't as flexible as mine.
Sure.
I can leave the office, I can largely choose my hours as long as I generally follow the, what's expected of me. My clients don't have that option, and so 8 to 4 does feel very restrictive. I do appreciate that staff need lives. They need to have some routine in their schedule, but how do we accommodate individuals who aren't as able to leave their work during those hours?
Yeah, that's right. It's a great question. And I anticipate, I probably should have said this, Stephanie, I anticipate this being a temporary 8 to 4 with the hope or anticipation even that once our substance screener, who's full-time, comes back in August-ish from her leave, that we go back to that 7 to 4 window. But you're right, and we have changed in the last even year. That window started as early as 6 a.m. back when we had someone who we contracted with, a contract employee. And then when we pivoted to the employee being a county worker, we, again, reduced those hours. So I'm aware that it has definitely caused some challenges for clients. I don't have a great answer to that right now, other than saying it's what we have to work with staff time. But we have had discussions about extending the hours to nights, not necessarily weekends. But for right now, that 8 to 4 window is really only what we're going to be able to do as a staff. But if others have ideas, by all means.
Yeah, I think the other thing I would throw in there, Phil, is the government center, once the remodel is done, the hours of the front security, because everyone will have to come through front security then, we are going to open at 7 a.m. to accommodate Justice Support Services and DOC if they end up coming into the building. But it is 7 a.m. to 4:30 p.m. is the window, and there's no access into the building other than going through that front security. So that'll be a limitation on your department also.
Yeah, thank you. And I appreciate it. And the reason why I should add, the reason why we ask for clients to be there by 4 o'clock is if somebody needs a different type of test as opposed to like a urine screen. So we do urine screens, we do oral fluid tests. The oral fluid tests take about 20 minutes to administer. So we build that time in for staff to make sure that those tests can be done. But yeah, I mean, there are unfortunately time constraints. There were time constraints even if we were in New Richmond. They have building hours as well. But Stephanie, your point is, it's very fair.
Phil, I just had one question. When individuals are going to New Richmond, do they go to the front desk? Where do they go?
Yep.
I've had that question a couple of times.
Another really good question. So thankfully, the front staff in New Richmond have helped us put some signage up because I didn't think about that, and I just was assuming people knew where to go, which is a very poor assumption. But yeah, they'll go in the front door, and then the front desk is right there, and they can certainly ask someone at the front desk. But there is signage that directs individuals to justice support testing, which if you're familiar with that building in New Richmond, we are just to the right of the front desk there, formerly room 156, thank you, Shar. But yeah, there's signage directing them. Sure.
Any other question regarding testing? No? Okay, then on to the MAT grant updates.
So I'll lead, and then hopefully maybe Shar will jump in on this as well. So our MAT grant, our medication-assisted treatment grant, that we've been now operating for at least a year and a half. We have roughly 4 or 5 months of funding left from the Department of Justice. So again, this collaborative project between Justice Support, Behavioral Health, and certainly the jail is to identify individuals in the jail who voluntarily want to participate in a medication-assisted treatment program where they can work on their recovery. So we are continuing with this with the understanding that the funding is really, again, finite or limited, and we continue to look for additional funding options. I know that Behavioral Health has some grants that maybe we can use to continue this program, but I do believe it really is about sustainability. And I guess one thing I've been thinking about recently for everyone in the justice system, but certainly our department, behavioral health and jail, to talk more about is what do we want to see from this program, this MAT program, for folks in the jail? Do we value it? I think the answer to that is yes, but what is our philosophy, I guess? And then from there, maybe we can continue to look for funding sources that can take us through the next several years. Because there is, again, we've been tracking folks as they go into the community. So the idea is that they start the MAT medication in the jail, again, voluntary. And then once they're released, we would follow them into the community to the extent that they're interested in continuing on in the program. So receiving the medication every 30 days in conjunction with referrals for counseling and so on and so forth. So we've served a small number of individuals, but I still think there's a lot of value to the program for the justice system, for behavioral health, and for the community at large, for those individuals struggling with opioid use disorder, alcohol use disorder, whatever it may be. That's kind of where I would stop. Shar, do you have anything to add to that?
Sure. Well, first, I think it's important to know that it's becoming mandatory in different parts of the United States. So I think having a plan is a really good plan. Definitely room for some improvement. So at the start of the MAT, Southern Health was providing the nursing and the med management piece. And they quickly found that they didn't have capacity to do that. And so behavioral health, we had our nurse and our psychiatrist kind of piecemeal together an ability to see the clients on site, do whatever they needed to do, and then the psychiatrist was telehealth. And since then, we've had turnover for both. Our psychiatrist is reducing his time, and then we got a new nurse. So we got up and running maybe 2 months ago again. And so I think we have a system. We have a nurse practitioner, mental health nurse practitioner who is able to do the med management. She's also a nurse. So we're looking at, can she just be one-stop shop, do all of it instead of having two people involved? The current sticky widget is trying to find a lab that is willing to contract to provide some of these services. I've never had so much problems connecting with getting a contract. Looking forward, I do think, so the State Opioid Response Grant, the SOAR grant, is one that we could very likely use to continue this, and it's through SAMHSA, and it's monies that aren't as soft as some of the other monies we have. And because in the last year we have had a tremendous growth in the amount of SOAR clients that we have served, I think we have a really good justification of asking for more and asking for money specifically to help support the MAT grant in the jail. I don't have numbers. I don't recall the last chunk of numbers that I've seen.
I don't either, and we can get with Tim and see if he can maybe come back in July and show us where we're at.
So we, at Western Wisconsin Health, we run a community medication assisted treatment program that is partially funded by St. Croix County. And that program has also been up and running for about 1.5 years. And we're just really starting to see an increase in patients. We have about 30 patients that we routinely follow. And that number has increased since the closure of Sacred Heart and St. Joe's in Eau Claire and Chippewa Falls. And I think that there can continue to be some synergies between this jail-based program and the outpatient services that we provide. About half our referrals currently come from St. Croix County. And we do have some increased capacity, so I think that's a partnership we can continue to explore through Behavioral Health Subcommittee as we work through optimizing that program. We've been very grateful for the support from the county, as well as the peer support, recovery specialist, LADC. All of those elements are really critical to running a successful program of that nature. And we too plan to apply for future grants to help support the ongoing funding of that program.
I was just going to say that was one of the things we just discussed on
how can we, what's the sustainability and how can we have that continuum of care from the jail right to that outpatient services in Western Wisconsin Health.
Well, it's good to see collaborations coming out of our subcommittees. It makes this feel very worthwhile. Thank you. Any other questions about the testing services, Matt Grant updates? Okay. Phil, could you give us a recap from the National Council for Mental Wellbeing Conference?
Sure, I'll start and then pass off to Shar. So back in April, Shar, Lopez, Natalie Radich, and I went to St. Louis for the National Conference on Mental Wellbeing as part of our MAC grant. I think, again, I guess maybe I have two takeaways. The first one is what I had already said, is I think we just need to define what our philosophy is for the jail MAT program. It sounds like we do want to continue it, which is great, but I think what direction do we want to go? And there are grants available out there. I'm going to go in 3 weeks over to St. Paul for kind of a national CJCC meeting. And one of the things that they're going to discuss is a federal grant, the Byrne JAG grant. It's BYRNE JAG, which is named after a law enforcement officer who was killed, unfortunately, back in the 80s. And they fund a lot of different things. And I was reading through it recently, and one of the things that they do fund nationally are MAT programs. And so maybe there's an opportunity there. I don't know, but I hope to come back with some more information for us. But there are some really innovative things going on with MAT throughout the country. I went to a presentation, and Shar and Natalie and I kind of broke up to do different presentations and topics, but there's a program going on in Western New York, the Buffalo area, and it's a 24/7, 365 MAT program for individuals that are in crisis. It's an emergency MAT program, I should lead with. So folks that are releasing from prison or jail or just in the community, they call like a hotline and they get pre-screened by an individual through a series of questions. And if that individual believes that they would meet the criteria for emergency MAT, they receive a text and a link, that a Zoom link or whatever, that a doctor will join them on within 15 minutes. And the doctor will then kind of screen them for that emergency MAT. That caught my attention. I'm not saying that that's what we're going to be doing here, but it's something that really is like pretty cutting edge. Obviously you would have to have partnerships with doctors that would be on call. And, I think certainly, and I'm not a medical practitioner, so Ailey, I think maybe there are some, I don't know how you weed out those concerns about screening people over a telehealth call for MAT, even in an emergency situation where you're giving them, let's just say 48 hours worth of medication. Well, I don't know what that looks like. So, I found that is very interesting.
So we do offer medication-assisted treatment within our emergency department, which we found to be a successful model. Several hospitals do that. And then it's our own mini hub and spoke model. So when the patient indicates that they are ready, which can be any time of the day, 3:30 in the morning, they can present to the emergency room, have a conversation with the physician and the social worker who's on, start to receive that first dose of medication, and then be scheduled for a follow-up appointment for outpatient ongoing medication-assisted treatment. So that's where the hub and spoke model comes in. And that is a very effective model. All of the emergency room physicians in our hospital are trained to do that. And that's meeting the patient when they're ready and when they're available. And so that is sort of our model of what you're describing. The patient needs to show up. We have found that we've been hard pressed by a telehealth model, because if a patient has indicated that they're ready, it's generally in that moment. And then how do you get them the prescription, and how do they get to where that medication is going to be available? Whereas if they present in person to the emergency department, the medication is immediately available. So that's been a successful model for us, and certainly something that feel free to promote and refer clients and community members as you hear about this occurring.
So first of all, it was probably the most professional training I've ever been to. It was there was smoke and there was lasers and it was the honestly the best conference, and we got to see Michelle Obama, so there was that. So some of the things that I went and listened to were on a certified community behavioral health clinic, which really is they're called CCBHCs, and Wisconsin only has 2 of them, but they're popping up everywhere. SAMHSA is offering a really nice startup grant, and it's really a one-stop shop helping folks that really struggle to get all their needs met. So it wouldn't just be behavioral health. We have a meeting next week, and we invited Western Wisconsin Health to be on the meeting just to learn more about what it looks like in Wisconsin. So that's actually it's exciting because it's really what we're doing. It's a lot of the things we're doing, but it's in a much more structured way with purpose. And maybe some extra funding that can come with it. So we'll find out more about that. A couple of the ones I went to talked a lot about peer support, and we are really fortunate to have our peer support programming. We have, for sure, we have our peer supports. We have 2 that we contract with Northwest Passage right now through the end of '24, hoping that we can extend that with some of the funds that weren't spent through the ARPA a little bit into the 2025. Still is not an MA billable service. We've been promised by Forward Health that it will be coming, but it still isn't. So that would be another sustainability that I would hope that we'd be able to maybe find another grant to be able to pay for. Also might be able to be covered under our SOAR grant if we were able to do that. Mental health first aid, they had National Council for Mental Wellbeing owns mental health first aid, and so they kind of tied that into a lot of things they did. One of the things I learned about is there's a new curriculum for mental health first aid for older individuals, so looking at trying to get that kind of training to those who need it. And one that I went to because I was curious, there's a ketamine-assisted treatment program in Hudson, and I don't know a lot about it, so I just went to learn more about it. It's something that is very successful with folks who have treatment-resistant depression. Kind of counterintuitively, it works well with substance use treatment, and there's a lot of research behind it. So I was glad to hear that is actually a good intervention for a small. It's for the right population. And then we went to a couple other sessions that really were, talking about New York City and those kinds of things and the really creative things they're doing there, which is great for homelessness, but we don't have a lot of those things here. So I was hoping to find a little bit more. But overall, it was an excellent learning opportunity.
Thank you, Shar. Any other questions about that? No. Okay, well, clearly the large majority of our topics here deal with substances and addiction and the need for treatment for that. So we are lucky to have John Curtis and Mike Early here today to give us a presentation regarding the retreat, which is a 12-step residential treatment program in Wayzata. So thank you, gentlemen.
You've got one right.
So, this is Mike Early. I'll let him introduce himself first.
My name is Mike Early, and I'm back in St. Croix County after a number of years' absence. My first job in the alcohol drug field started after I completed counselor training at Hazelden in 1972. My first job was to work for St. Croix County on a grant project for a halfway house, and that halfway house became Kinnick Falls Halfway House in River Falls. In 1974, I started working for St. Croix County Alcohol Drug Services as Director of Prevention, Intervention, and Outpatient Services at the Health Center in Richmond. Then I became the Alcohol Drug Coordinator from 1981 to 1989. And then I skipped out of St. Croix County, went to Hazelden Parent Treatment Centers out in Pennsylvania. I retired, I unretired, I retired again, and I unretired because John Curtis, who I worked with in the 90s at Hazelden, was running the retreat. And he's going to tell you all about the retreat, but I couldn't think of a better thing to do in the twilight of my career. I'm a little gray, but in the twilight of my career than to do business development work with the retreat, something I totally believe in. So, John Curtis.
Oh, thanks, Mike. So, yeah, I've been in this field for 47 years now, 20 years at Hazelden, and I started as a counselor and worked my way up into eventually the vice president of the national continuum for Hazelden. So I set up Hazelden, New York, Chicago, some of Florida, and ran units up in Center City for a number of years. And then 26 years now at the retreat. And I want to talk a little bit about this. This is a unique model of care. And I think I just pushed this. By the way, Mike and I left our laser and smoke machine at home, but we'll next time we'll bring it. Just briefly, now I brought more slides than I have time, so which is why I printed them all out for you. So I'll skip through some of this stuff because much of this information you already know. You know, there's between 23 and 25 million alcoholics in our country. 15 million Americans abuse opioids, depressants, stimulants every year. 107,000 people are dying of opioid overdose deaths. Obviously, fentanyl changed the world for all of us. You know, Big Pharma has a way of inventing these drugs that one dose can kill you, and the margin for error with fentanyl is 0. 46 million or 49 million people smoke marijuana in the last 12 months. That number is growing, obviously, for all the obvious reasons, legalization and everything else that's going on. So we'll see that number go up significantly. But 14 million are meet the criteria for cannabis use disorder. 5.2 million Americans use cocaine and crack. So every year we lose about 250,000 people to substance abuse. It is the #1 health issue in our country, and it's costing us about $600 billion in health care costs, low productivity, disability payments, welfare, crime and punishment, legal and court costs, family breakups, child abuse, the whole array of social interventions that go into helping to address this problem. If you add tobacco to the issue, we're talking close to $1 trillion of cost to our society. Hospitals are overwhelmed with victims of auto accidents, home accidents, liver and kidney disease. Abusers and addicts are crowd clogging our courts. And about 80% of people that are adult and juvenile inmates are incarcerated for felonies are involved with a drug-related or have a substance use issue. According to the Minnesota Department of Human Services, about 10% of the people who need help get it. Now that number is more of a national number too. I think it's probably consistent here in Wisconsin as well. That 90% of the people out there that need help are not able to access the help. Now, some of that is they're not ready yet. They don't identify the problem, and about, according to SAMHSA, about 40% of those people, it's the cost of care that keeps them from getting the help they need. So, you know, we're not going to solve America's addiction problem by developing more $30,000 to $80,000 a month residential treatment programs. You know, at Hazelden, when I started there, it was $1,600 a month. Today, it's $50,000 a month, and that's consistent with treatment across the country. So we have to find a way to drive the cost of care down and access up. In 1991, while at Hazelden, the Johnson Institute pulled together a group of professionals, 50 people, and flew us down to Captiva Island in Florida for a week-long think tank. And this is 91, so we could kind of see the writing on the wall that you know, access to care was diminishing, the cost of care was increasing, and outcomes were starting to diminish. We said, that's not a good metric. So they flew 50 people representing criminal justice, researchers, SUD professionals, and you know, what are we going to do? What do we have to do to serve more people for less money and to address this problem? And this was at a time, looking back in the 1970s, you know, Hazelden, the founder of the Minnesota model of treatment, which basically was that alcoholism and drug dependency is a primary progressive chronic fatal illness, and that the people that are suffering from it deserve to be treated with respect and dignity, and that there is hope. And at that time, the model of choice was abstinence and active involvement in 12-step recovery. And even today, that modality of care is still proven to be the most effective way to help people. Harvard just finished a study, actually the Cochrane Review, which is 38 different studies from around the world, and they tracked 10,000 substance use disorder individuals for 3 years and put them in various modalities of care. And what they found was that over that period, the people who went into the abstinence 12-step model of care had a 20 to 60% better outcome at every touch point post-treatment, 3, 6, 9, 12, out to 3 years. And their time to gain that full recovery capital in their life, that's kind of the new term out there, recovery capital. And basically it means that, you know, you have a supportive community of friends, you have financial support, you're able to, you have a job, you're pursuing your education, that you get kind of what most people get in their life when they grow up. They develop all the capital to have a full, meaningful, productive life. For somebody in recovery, it takes about 5 years of recovery to begin to develop that amount of recovery capital. But during that decade of the 70s, more people got well in the United States during that decade than the previous 50 years. It was a revolution. Every hospital had a 20-bed, 28-day Minnesota model program around the country and around the world. Now, managed care stepped in the 80s, late 80s, early 90s, and said, we want to squeeze the bottleneck. We're going to try to save money. And, of course, what they think of is saving money for, this quarter or this year. And what we were telling them back in those days is, if you restrict people from getting the care they need, you're going to pay tenfold over the next 5 years, not just with their health care costs, but their family's health care costs. Because we found that in recovery, that individual's use of health care dollars diminishes by 50% over that 3 to 5 year period of time in recovery. And also their family's involvement with health care, their expenses diminish by 50%. Everybody gets healthier. The insurance executive pulled me aside. I gave a talk like this in New York one time, right when managed care was really getting its grip on Minnesota and California. And he said, you don't get it. And I said, what don't I get? He said, most people are in our plan 2.3 years. So we don't see the long-term impact. But I said, what about the health of the society? Because at some point, they're going to come back into your plan. And we're going to end up with a sicker society if we don't provide the proper care at the right time for people, the full continuum of services that are needed. So after this think tank in '91, Dr. George Mann, who was the founder of St. Mary's Treatment Center in Minneapolis, and myself and medical directors from treatment centers around the metro area, and longtime recovered men and women and business leaders all got together and met once a month and said, let's come up with another model of care that can help more people for less money and produce good outcomes. So that was a 7-year process. And we brought in social model movement people from California and some of the originators of High Watch Farm that Bill W., the founder of AA, created in 1939. We looked at what Hazelden looked like when it opened in those early days, Pioneer House. They were recovery retreats where people could kind of get out of the burning house and step away from all their enabling friends and family members and focus on what do I have to do to live a happy, sober life. So from that, in '95, I wrote a business plan and called it The Retreat. I was coming up with just a filler name for the business plan, and that name stuck. And then eventually we found a building, and we started something. And the board said, do you believe in this model enough to leave your cushy job up at Hazelden to make it happen? And it was kind of hard for me to say no since I wrote the plan. And so I did. And we started as a 19-bed experiment. Could we create kind of this retreat model program? And this is interesting because all of us were medical people. I have a master's in healthcare administration, and we had all these medical directors from treatment centers, and we said, you know, the answer really is out of healthcare. We have to drive recovery back down to the level of the community, so that, because that's where recovery happens. The healthcare part of it is in, you know, detox and you know, putting together a primary treatment plan and all of that. But at some point, the person is going to be out in the community, and that's where recovery happens. So what can we do to integrate the recovery more into the community environment? So the retreat opened 26 years ago, again with 19 beds. We're non-clinical mutual help support environment. And what we did is we went to the 12-step community, and there are, of course, great AA meetings everywhere, and then there are these really bright light meetings where you have groups of people who sponsor each other. They do a lot of service work. They're very active in the service of others. And we said, well, let's partner with these folks and have them come in and help deliver the curriculum. So the idea of the retreat model is to take people who have the problem and want recovery. They know they have the problem. 80% of our people have been to 1 to 5 previous treatments. They're smart. They know all the words. They can't hear the music, but they've got the words down pat. So what can we do to help you know, give them the education about the problem and where the solution is, and connect them to the 12-step recovery community, AA, NA, Al-Anon, all of that. And it turned out the community was like, oh my God, we were, you know, at Hazelden, we always had volunteers come in and give the AA orientation. Don't really talk to the patients. Don't tell the patients what to do. That's the counselor's job. Well, in this model, the agent of change is this community of people who come in and share their message about how did I do this? And you know, when we started, again, it was a small experiment, and we had this research company that out in Oregon that measured everything because we wanted to know, would this model work? We started, it was $2,600 for a month stay. And with that, we gave scholarships away. So for some people, they come in with a couple $100. We know that outcomes are better if they have some skin in the game. So the retreat has grown, actually beyond our wildest dreams. There's a video in there, but it doesn't show up. But if you go on our website at theretreat.org, you'll see a whole bunch of videos about our model of care. But today we have grown to now 171 beds. We moved from the old Pillsbury Gale family property in Minnetrista, Minnesota, to Wayzata 20 years ago. And so from that, we have, you know, a 41-bed center for men's recovery, 30, 60, 90 days, a center for women's recovery, 32 beds. We have a relapse program. We have evening programs, which are our outpatient versions of treatment. Virtual recovery programs, which was kind of the gift of COVID, that everything went virtual. And it turns out there are people from all over the world now that want to dial into the virtual recovery program. So we do that as well. Family program is critical for us. If you can get the family involved in that person's life and recovery, and you get them, you know, working their own recovery program, the outcomes are significantly better. So we put a lot of energy on getting the families involved. Long-term sober living. We have 6 long-term sober living homes along by the Governor's Mansion in St. Paul on Summit Avenue. When I first wanted, 20 years ago, I wanted to open up a sober home, and I asked a buddy of mine on Grand Avenue, I told him about it. And he said, well, were you thinking east side of St. Paul or North Minneapolis? And I said, well, where do you live? Well, I live on Summit Avenue. I said, that's where I want my people to live. He said, well, you ought to buy my house. So a month later, I did. And now we have 6 homes on Summit. And it, you know, they pay $600 to $800 a month, depending on the house. Most people live in our sober living environment for, you know, 18 months. They have to work, they have to go to meetings, they have to do service commitments in the community. They have to be a part of the vibrancy of the recovery community. Kids camps, spiritual retreats. I mean, the retreat has now replicated this model in 13 locations around the world. We have the retreat in Sydney, Australia, Auckland, New Zealand, Hong Kong, Nashville, Vero Beach, Florida, Ireland. We're working with Trey Anastasio from Fish, the band Fish, who's coming out to the retreat tomorrow to set up a retreat model in Vermont. And so it was the right idea at the right time. And we've been able to help 31,000 people from around the world access recovery. We've researched this model for 16 years, and now we're in the middle of a 3-year outcome study with Harvard and Mass General, Dr. John Kelly, who's one of the top researchers in the country, and he's measuring all of our people for the next 3 years to again validate what we kind of see, you know, day to day, that we know it works, but you know, it's better to have it on good stationery from somebody that is objective, that can look at what you're doing. Most of our people are multiple agent users. Alcohol by far is still the #1 drug that kills the most people in our country. And the second most abused drug in our world is cannabis, and then amphetamines, and then, you know, further down the list are the opioids. Obviously, opioids get a lot of attention because there's just, again, no margin for error, and it's killing a lot of people. So the MAT strategies are critical for that population in terms of helping them to kind of quiet the noise and the obsession of the mind that keeps triggering them to relapse. However, there are many opioid addicts that we're serving that have had a long history of abusing MAT medications. So we do allow people on Vivitrol and on occasion Sublocade injections. That gets the strips kind of out of the picture, so they're not, you know, passing strips around, and we're having to deal with that daily peak and valley of milligrams. The Sublocade seems to be a much easier way to kind of deliver the MAT medications. But again, most of our people by far are alcoholics that use other drugs. So that's kind of our model of care. We have our outcomes show that we have 53%, and it goes between, if you look at on our website, you'll see all the different studies that we've done, and it fluctuates between 52% and 62% of people will be completely abstinent for the first 12 months of their recovery, which most relapses after treatment across the country, after, you know, Caron Foundation, Hazelden, Betty Ford, all of them, happen in that 3 to 8 week window when somebody gets out of treatment. The first 2 weeks, everybody's patting you on the back, and you're on the pink cloud, and you're excited, and you got a lot of support. But then, you know, that third week, the ego reemerges. The old relationships start popping up. And before they know it, they're back on the luge track again. So the more we can keep people connected to front row 12-step recovery, the better their long-term outcomes are. And it turns out the community is enhanced by the retreat being here, because it's a playground for all these recovering people to go in and carry a message. So it's helping them too. So it's created this vibrant environment of hope and recovery. And here's some information about various researchers and what other people say about us. Today, the cost is $6,900 for a 30-day stay. Our 18-week outpatient is $3,400. We give away about $500,000 in scholarship every year. So money is not going to block somebody from getting the help they need. They need some skin in the game, but we've got a guy coming in from Aspen, Colorado today that came up with $50. And we said, well, okay, that's a stretch for us, but he wants it, he needs it, and he's coming. So that's a bit of an overview of the retreat model of care. Any questions? Yeah.
So I was just wondering about other funding, so not MA billable, third-party insurance.
It's all self-pay because we're technically not treatment. Okay. We're a community-based retreat model of care, supportive educational rather than medical clinical. So insurance companies have yet to, we've had a couple that have paid it, but not, okay. Which is why we raise a lot of scholarship money to make sure that we can address that issue.
Yeah, because I think from the behavioral health, because I work in the behavioral health world, I don't know that we'd be able to utilize our funds to pay for a service that isn't, because we bill MA and we reimburse, we can tap into other funds, but if it doesn't fall within that model you talked about, being a promising evidence-based programming being validated by Harvard at the moment. But before that, I'm not certain that like our funding through the behavioral health world would be able to fund that.
Yeah, now Washburn County is doing that with people going to the retreat. So they found a way to use some, categorize their funds in such a way that they can pay for that. But the Ramsey County Problem-Solving Court will help people go to the retreat. Some of them are paying with their own funds or family funds
Right.
and scholarship.
Yeah. It was nice to hear you have scholarships too.
Yep.
That was one of my questions.
Yep.
All right, any other questions for Mr. Curtis? Well, thank you for coming, giving the presentation, and thank you for dedicating so much of your life to such an important issue.
Thank you very much.
Yeah.
Appreciate it.
And you all have, just information, you all have my business card, and you all have a card, QR code on one side that shows the website, and then the other side, QR code that shows our brochure. So if you have any questions, I've talked to Phil. Phil invited me here, and anything I can do to answer any questions, my number's in my cards. Appreciate it.
Thank you. All right, we will move on to the subcommittee reports at this point. So, Phil, the executive subcommittee.
Sure. Executive committee meets next on Thursday, June 20th at noon. Excuse me, at noon in Branch 3 Judge Needham's courtroom. Again, the executive subcommittee meets to discuss agenda items for this group. So if you have anything you'd like to add for July's meeting, pass that along to myself or Judge Needham.
All right, Criminal Justice Subcommittee, which Judge Waterman was going to address, but he is not with us today. So, Phil.
Sure. So next meeting for the Criminal Justice Subcommittee is Monday, June 17th at noon in the new conference room 1700. Biggest update here is for at least, again, the last couple years, a lot of the work that would have otherwise been done in the Criminal Justice Subcommittee was being done kind of a little bit more informally in our pretrial work group, which was formed when Justice Support was created. We've found over the last several months that the majority of the members in the work group are the same ones that are in the subcommittee. So we're going to be dissolving our pretrial work group after our May meeting. Our next meeting is Monday, May 20th for that work group. And we'll still meet, the work group will still meet, the pretrial work group if necessary, but the Criminal Justice Subcommittee was kind of being starved of work. There was nothing to do, largely because a lot of that work was being done. So the Criminal Justice Subcommittee will go back to meeting every other month with June 17th as the next meeting.
All right, you are still on. Treatment Court.
Treatment Court Subcommittee meets next on Wednesday, June 19th at noon in, again, in room 1700. I don't think really any updates. But that will be our next meeting.
And moving on to the domestic violence.
Domestic Violence Subcommittee meets next on Wednesday, July 17th at 11:30 here in the county boardroom. DA's office will be doing a brief presentation regarding how they process domestic violence, interpersonal violence related cases.
And Anjali Patel is here to give us an update on child welfare and juvenile justice. Thanks, Anjali.
There we go. So probably the biggest update since the last meeting is we are going soon to print for the parent pamphlets for CHIPS cases. So we're still severely understaffed in terms of attorneys willing to represent parents in these cases, and so we've created basically a handout to explain how the cases are processed for them, what their options are in these courtrooms, things of that nature. because of the work that we put into that, there's now discussion about creating that type of pamphlet for parents and kids in juvenile delinquency cases and CHIPS cases, so we'll probably be moving on to that next. An ongoing topic that we've been discussing is truancy. So we have a small subgroup within our subcommittee who have volunteered to attend trainings through the Department of Public Instruction and the Department of Children and Families for family engagement in truancy cases. So we're hoping to sort of implement some of those things here in St. Croix County, see if it can assist us at all in working on these truancy issues. But those are probably the biggest updates we have for now.
I just have a quick question. Do you think there'd be any possibility of getting a volunteer who has some experience with CHIPS cases that might be available for the legal clinic? I do the free legal clinic first Wednesday of every month here, and I cannot tell you how many questions we get about CHIPS cases, and we very rarely have an attorney that knows what the heck to tell anyone.
Yeah.
And they're now at least remote, so you could, I answer, we get a email that says call this number, and so we don't have to be here anymore. It's a pretty flexible thing, but that would be really wonderful.
I can chat with the two attorneys who are handling most of those cases and see if either one of them are willing to do it. They do come from pretty far away, and so I will chat with them and see if we can ask them to step into that role.
Okay, and you can contact me about that if you want to.
Okay, sounds good.
Thank you.
Any other questions?
Okay, and Shar, behavioral health.
We did not have a meeting. Our last meeting was canceled due to weather, and our next meeting is on the 20th, so hopefully it will not be canceled due to weather.
Thank you. And Phil noted earlier that if you have any suggestions for future agenda items, if you have them now, feel free to let us know. Otherwise, go ahead and contact Phil or Judge Needham. Any agenda items at this point? Sure.
I don't have an agenda item, but I just want to make a comment about the mental health symposium that the county held last week. It was wonderfully done. I want to commend Shar and Phil and the team on putting together a truly wonderful representation, and grateful that our county has such excellent resources to provide to our youth. So thank you.
Thank you for that. Any announcements?
Okay, I should just add, because I think I forgot, the next meeting of the Child Welfare Subcommittee is Thursday, May 23rd at noon in the 1700.
And I would just like to announce that CASA is having its annual gala coming up on the 16th at White Eagle Golf Course. This is our second one, and I think we are like 5 people short of max capacity, so that is really good news. It's very encouraging. And we would just encourage anyone who would like to support CASA, and if you can't go, there is a website too where donations are available for the program. So, all right, any other announcements? All right, then it looks like we are adjourned. The next meeting is July 11th, still in the county boardroom here. Thanks.